Welcome everyone to another Lunch and Learn. I am super excited about today's presentation. But before we get into our presentation, I want to throw it over to Therese to tell us what's going on at the chamber. Therese, what do you got?
Well, you know, Howard, we are so busy with so many events, and thanks for putting it out on your email I saw come out this weekend. So as you all know, we're a very active chamber, and we have tons of events on the calendar. You could go to monmouthregionalchamber.com to the events calendar to see it all if you want to register for anything. But just in a nutshell, I just sent out the email for next Wednesday, February 14th. We have our very first inaugural Zoom meeting for the Community Partners in Service group. They are brand new. We are now bringing our nonprofit members together with the for-profit sector because we want to see how we can help each other. The nonprofit world and the for-profit world have things to offer each other, and so that's why we created this group. And next week we have a Zoom meeting. And so we're going to talk about the group and how and what our direction and our mission is. And then we have a speaker that's going to talk about some fundraising that's available for nonprofits that I might not be aware of. So that's going to be an important call for everyone to hop on and listen to and join in the conversation. And we will be doing the round robin 30-second commercials afterwards. So that's that. And remember, every Friday we're at the Marlboro Diner. It's around 7:30 till 9 o'clock in person. If you want to have a delicious breakfast, come and join us there. And it's a great networking event. We had 31 people this past Friday, so it was really crowded and we loved it. The only thing is the last Friday we do it on Zoom. So don't go to the diner on the last Friday. We do that meeting on Zoom for those people that can't get out there. I guess that's it. Oh, and Chambercast, Heart Health Month this month. It's on Monday, the 26th. And Chambercast is at Bellworks. We'd love to see you there in person. It doesn't cost anything. Great speakers. Dr. Pete, an independent cardiologist, will be the speaker. And lots of great information to share, so you don't want to miss that. And that is in person at Bellworks on the 26th, 8:30 a.m. till about 10.
Awesome. Thank you so much, Therese.
Thank you.
So February is National Cancer Prevention Month, and working with our great partners at CentraState healthcare system. Today, we have Dr. Itskovich, who's going to be talking about high-risk cancer screening. But we are so proud and so privileged to have the doctor with us today to take us through this presentation. I can tell you firsthand, the devastating effects that cancer has, certainly on my clients. I see it, unfortunately, stage 4, whatever type of cancer they have, is really tough. It hits the families really hard. Obviously, the people are affected, and, it's really tough to see that happen, not only to the person, but their loved ones. And unfortunately, in my business, I get to see that far too often. So what I'm hoping that we can get out of today's presentation is a little bit of prevention, right? And a little bit of best practices of things that we can do to better protect ourselves, educate ourselves in terms of the risks and some of the screening opportunities that the hospital may have for us. So I'm really excited to get this information, and I'm really so thankful for Dr. Itskovich to take his time to talk to us today. So please allow me to welcome Dr. Itskovich. Doctor, take it away. You're on mute, sir.
Thank you very much for the opportunity to be able to speak here. I think high-risk screening is something that is relatively new to the region. As CentraState continues its partnership and to expand its partnership with Atlantic Health, one of the things that's really become an opportunity is to develop what are called tertiary level services in the region. that allows us to really offer folks things that were not offered in the past, and high-risk screening is one of them. So everybody knows, I think, in the community that you need to get your mammogram, and then you need to go get your colonoscopy at age 45. But there are other opportunities to screen that can prevent cancer in very specific patients, and that's actually what we're going to talk about. And it's an offering that CentraState now brings to the community that is, I think, unique and a big opportunity to save lives. I'm going to share my my screen here. 1 moment. All right. Let's see. Is everybody able to see that?
Perfect.
All right, perfect. All right, so today we're going to talk about high-risk screening, and I'm going to just give you an overview so that I think folks can understand, you know, what it is that we're talking about and what makes it different than the standard screening. So several goals of our presentation. What is high-risk screening? How is high-risk cancer screening different than general screening? What makes someone a candidate for high-risk screening? And then we'll talk about what are some examples of high-risk screening, and what should an individual do if they believe they are at increased risk. And I think these are really important questions to answer for, you know, for the folks in our community.
Here it is.
All right, so what is high-risk cancer screening? So high-risk screening is the process of identifying individuals who are at increased risk for cancer compared to the general population. So what does that really mean? So for example, every woman that's born with 2 X chromosomes will be at risk for breast cancer, and that breast cancer risk will be 1 in 8, and I'll talk about that a little bit later in my presentation. But that's just inherent to the population. But there are certain women where that risk can go as high as 60 to 90%. How do we identify those people who are at a particularly increased risk, and what do we do about that population, which is different than the general population? So an example of an individual risk that may be hereditary is something like a risk for pancreatic cancer, which we know to be familial in about 15% of cases. Other risks can be environmental risks, like, for example, smoking in the setting of lung cancer. So what is the difference between high-risk cancer screening and general cancer screening? So the general population has a baseline risk of cancer. So like we talked about, 1 in 8 women will develop cancer. However, the general population has a relatively low risk of developing lung cancer, but that's not the case if you smoke. If you smoke, that risk can go as high as 1 in 220. So at that point, something should be done for that subset of the population, that and that is what high-risk screening is. And in those particular patients, we actually do recommend low-dose lung CTs every single year, which is not recommended in the general population. So it can get confusing. And I think that, we want to make sure that we are being very, very specific about what we're talking about here. So 12.5% of women will develop breast cancer in the general population and should be screened with mammograms. However, a woman who is high risk is considered somebody who has a greater than 20% chance of lifetime risk. So that's different than the general woman. So the general woman has a 12.5% risk. A high-risk woman has a greater than 20% risk. And that can be based on genetics, or that could also be based on some computer models that we perform at CentraState for women who receive mammograms here, specifically something called the Tyrer-Cuzick model. And women who are at greater than 20% lifetime risk of breast cancer benefit not only from a yearly mammogram, but also the addition of a yearly MRI to that mammogram. Now, there are also women who have an overwhelming risk of breast cancer. Those are your women with BRCA, with the BRCA mutations or some other rare mutations like ATM. And those women have a sometimes as high as 90% lifetime risk of cancer. And those women benefit from prophylactic mastectomy, which again, we also offer at CentraState. So this is, high-risk screening is really a range of diseases. It's not only looking at one particular disease, but it's a range within that disease as well. So what makes somebody a high-risk candidate? Well, there's really two things. The first is the individual has a family history that predisposes them. That's one option. The individual is carrying a genetic variant that has a known risk of developing cancer. So it may be a family history, or it may be that they just happen to develop that when they were born, that particular genetic variant. And that can sometimes happen. Those could be what we're called sporadic cases. And then there's another possibility is that the individual has an environmental exposure that increases their lifetime cancer risk, such as being exposed to radiation or being exposed to certain chemicals at work, or smoking is another environmental risk that's very common. The important thing to realize is that an individual's risk, although it could be elevated from the baseline population, does not necessarily mean that you need to screen. If your risk is relatively low above the baseline population, screening may not make sense. So, for example, I'm often asked, well, pancreatic cancer is so deadly. Why is it that we don't just screen everybody? Why don't we just, do CAT scans or MRIs on everyone and make sure that they don't develop pancreatic cancer every year? And the answer is actually because the risk-benefit ratio doesn't make any sense. And what does that mean? Well, so let's say that we, happen to, find that on a random MRI that somebody's pancreas has a duct in there that's a little bit big. Let's say the normal is 4 millimeters, and we happen to find that that duct is 5 millimeters. So now what we're going to end up doing is we're going to recommend an endoscopy for that person, and that person is going to maybe or maybe not require a biopsy. And if their risk is relatively low, the chances are that's a benign finding. But if that same duct is enlarged in a population of patients where they've had 2 relatives with pancreatic cancer, that duct probably is going to represent something, more than just a subtle finding. And so we don't want to put people through the unnecessary endoscopies, the unnecessary CAT scans, the unnecessary MRIs, provide stress in their lives, unless that risk-benefit ratio really makes sense for that direct individual. So why is cancer screening important? I think the most important part is finding cancer early improves survival. And below I have a chart here of the median survival for pancreatic cancer by stage. So in screening programs, so if somebody is a candidate for example, for a high-risk pancreatic screening program, we end up finding the pancreatic cancer in stage 1 or stage 2 about 80% of the time. Now, it's not perfect, but it's definitely better than the average population, where 75% of pancreatic cancer is found at stage 4. And if you look at the difference, a stage 1 pancreatic cancer has a median survival of 25 months. Now, you may think that that's not that impressive, but at a stage 4, their median survival is less than 5 months. So you really are making a dramatic impact on their survival by finding it earlier. And, many of those patients will live greater than 5 years. And last year in our high-risk pancreatic cancer screening program, we did find 2 stage 1 cancers, which is a dramatic impact on those individuals. So the other important part of it is that if we do find somebody who's at higher risk, it alerts the rest of their family that they need to be checked too. And it may be that the cancer doesn't develop in that individual, but it may develop in their uncle or their niece or their sister or brother. And so it's important to have a family approach to these diseases, because that is what will save lives in our community. How is high-risk screening performed? So this is highly individual risk and cancer specific. So, for example, one of the ways that we screen for colon cancer is we do a colonoscopy, and the general recommendation is that's done every 5 to 10 years. But in certain high-risk individuals, that colonoscopy may need to be done yearly, and that is the method of screening in that particular disease. Other diseases, we screen with a combination of things. So in general, cancer screening is done through a variety of techniques. One of them is physical examination. So, a breast exam or a prostate exam. certain types of blood work. We do genetic testing and tumor markers. We do imaging, CAT scans, ultrasound, MRI, depending on the type of cancer. And in other situations where things are a little bit more advanced, we do colonoscopy or endoscopy or surgical diagnostic procedures to screen. And then the most radical thing that happens is that when we know that somebody's at an exceedingly high risk, we remove the target organ in question. So, for example, in BRCA, we would remove, we would do a bilateral mastectomy. Or, for example, when somebody has a very rare CDH1 mutation for gastric cancer, we actually remove the stomach prophylactically, surgically, because that person may have a 70% lifetime risk of developing gastric cancer. It's an entire spectrum of how we approach the problem. So who is at high risk? So broadly, it's divided into two categories: genetic predisposition, so either family history, or environmental predisposition. So, either your work environment or your personal decisions have led to that increased risk, such as smoking or other environmental predispositions. And both of these have different screening programs are available. So, for example, in the genetic predisposition arm, which I'll show you a little bit more about, we screen for a variety of cancers. And then in the environmental predisposition arm, we also screen for a variety of cancers. So lung cancer is, kind of the prototypical high-risk screening, where we offer it for smokers. In the genetic predisposition arm, it actually gets quite complicated, and I'll go through that in a second. So here's some examples of high-risk screening programs. A yearly lung CT in a patient with greater than a 20-pack year history of smoking. A yearly MRI in patients with an extensive family history of pancreatic cancer. Biannual ultrasound in a patient with liver cirrhosis to look for hepatocellular carcinoma, which they're at risk for. A yearly MRI in addition to yearly mammography in a woman who's at greater than 20% lifetime risk of breast cancer. So I guess, the message that I want to bring here is that this is a very broad and applicable thing to a variety of diseases. So you really do need to contact your healthcare professional and have them advise you on which screenings that you may be eligible for given your individual risk, because this is not one disease and many screenings are applicable to multiple diseases, as I will show you. So, the purpose of this slide is just to kind of illustrate a point where, I just want to show you that it's complicated. And it's complicated because, for example, let's say hypothetically that we do genetic testing on somebody who comes in to see me because their brother had pancreatic cancer, which is kind of common. And we end up finding that that person has an ATM mutation, okay? That ATM mutation will now tell that person that they are not only at increased risk for pancreatic cancer, but also increased risk for breast cancer and ovarian cancer and potentially prostate cancer. And that individual will then have to enter a screening program with multiple physicians monitoring each of their subspecialty areas to prevent that individual from developing cancer in that area. And it is through this kind of remarkable intervention that we can prevent cancers. We had one of the stories that I tell often, is we had an individual who was found to have a breast cancer, and subsequently through genetic testing, we identified a gene and then ended up having a colonoscopy and ended up finding a colon cancer, all in stage 1. A great opportunity where we were able to save that individual's life by preventing two cancers that were actively there just because their family member had a genetic predisposition. So a CDH1 mutation is another example. That person has an increased risk of breast cancer and an increased risk of gastric cancer. And the gastric cancer risk in that individual could be as high as 70%, where we would be doing a removal of the stomach and then monitoring for the breast cancer in that individual. So the way that we do this at CentraState now is we have a highly coordinated effort among our screening program to monitor patients. And so if somebody comes in and let's say they have one of these mutations, we refer them into all of the high-risk screening programs that they need to attend based on the guidelines. And each of those programs gets coordinated through our genetics counselor and our team to be able to make sure that they're getting all of the screening requirements fulfilled and preventing as many of those possibilities. So the general message here is that when somebody has a positive gene, that does not only mean that they are predisposed to that individual cancer that their family member may or may not have had. That predisposition may give them a risk for other cancers, which then also need to be monitored in the high-risk setting. So genetic testing is now a large part of a high-risk cancer screening program in familial cases. We have a very extensive genetic testing program at CentraState, which we've built over the last 2 years. That program allows us to have, very specific expertise in this particular area, which not a lot of centers offer in the tri-state area. And what's also important to understand is we're only scratching the surface of what's known about genetics nationally. Genetics, although we've known a lot and studied a lot in the last 20 years, we're only scratching the surface. We oftentimes receive something called a VUS in our reports. A VUS is something called a variant of unknown significance. So we will get a report from a genetic testing company that we use, and it'll say, your patient has a variant of unknown significance. And so what we then do is we monitor those variants, over the course of the years, and we inform those patients whether those variants end up becoming something benign or end up becoming something where then an additional set of screening needs to be initiated based on those variants. And the important thing, again, to realize, and I think the take-home point here, is that many inherited diseases involve multiple genes and how they interact. And so it's complicated, and it's very important that if you have a extensive family history of cancer, that you be evaluated by the right team who can give you, suggestions on, how you can potentially prevent some of these diseases and extend your life. So what should an individual do to determine if they are at increased risk? Well, so I think what's important is that you need to, if you have a family history of an extensive family history of cancer, it's important to discuss that with your primary care doctor. I think that's really the first step. And if that primary care doctor really feels that you would benefit from additional screening, then they will refer you into our high-risk screening program, depending on the site of disease that your family member may or may not have had. And I think the important thing to realize here is that just because you have a family history does not necessarily mean, A, that you will develop the disease, and number two, does not necessarily mean that you will be benefited from screening. So a common, I think that's a common misconception. So I'll give you an example. So let's say a patient comes to me and they tell me that one of their first-degree relatives, so that means a parent or a child or sibling, has had pancreatic cancer. It's very, very common for me to see a patient like that in our high-risk screening program. And they'll say, "Doc, does that mean I'm going to get it?" And I'm going to say, absolutely not. Overwhelming chance, 97%, you will never develop pancreatic cancer. Actually, the baseline risk of pancreatic cancer in the population is 1.6%. So 1.6% of all people will develop pancreatic cancer. And having that single family relative only brings you to 3%. So in fact, if you do not have any genetic findings on the genetic testing, we will not screen you further, even though you have that one relative. And the answer is why? Well, our screening tests are good, but they're not perfect. So our screening tests, maybe are at 97%. But let's just say hypothetically that we had a 99% accurate screening test. And let's say we had that. So that would mean that if we are recommending a 99% accurate screening test for the general population, then out of 100,000 people, we would screen a good proportion of that population and get a bunch of false positive results for a very few number of true pancreatic cancers. And I think that that's the important thing to realize, is that this is a numbers game, and the only way you can screen a very large population is that if that screening test is 99.9999% accurate, which we do not have. So those people who are at slightly increased risk, they don't benefit from screening, and that risk-benefit ratio is not going to help them. They're going to be put through unnecessary procedures, and we want to make sure that that doesn't happen. However, if, let's say, somebody comes to me and they have 2 first-degree relatives with pancreatic cancer, well, now their lifetime risk is 8%. And in that situation, we can help you. And in that situation, you do benefit from that yearly MRI. And there is a higher probability in that population that if that MRI does show something, that something actually represents a real disease as opposed to a false positive finding. So I think really the sort of take-home message is that these high-risk screening programs are highly involved. You really do need to get consultation from your physician to, get advice on whether this is something that would benefit you or your family. And it's better to err on the side of caution and ask. But most people will not be candidates for high-risk programs. But if they are, then those high-risk programs will dramatically benefit them. And what I say to folks who are, in a high risk program is, if you have a lifetime risk of 8%, okay, there's still a 92% chance you will not develop pancreatic cancer. So overwhelmingly, you will not develop pancreatic cancer. But this is a life insurance policy for you, because if you do develop it, then we can catch it early and we can extend your life. And the data really supports that. And I think there's a really a true benefit in that subgroup of patients to help. Also, however, I also want to put that in perspective for you. So let's say somebody gets screened for pancreatic cancer and they're in a high risk program and they have an 8% lifetime risk. Well, is that high or low? Well, it's helpful to that individual. But if you have an average woman who has a risk of 12.5% to develop breast cancer, that individual's risk of developing pancreatic cancer, even though they're considered high risk, is lower than the average woman's risk of developing breast cancer. So that kind of puts things in perspective for you. It's a rare entity to find a positive finding in these situations. But you do have to find the population where it helps. And on a population level, these high-risk screenings save lives and really, I think, benefit our community. And with that, I know I've thrown a lot of information, in this presentation, and I want to open it up for questions.
Awesome. Thank you so much again for this. I think, for me, you highlighted, I know you kept on highlighting about how complicated it is. I kind of keep on going to how scary it is, right, for that person and for people that have concerns about it. I know you focused a lot today on the genetic testing, and I in the beginning of the presentation, I really didn't understand why there was limitations. I think you did a good job of explaining the value of the genetic testing, but my question is AI helping us move closer to being able to make that kind of more of a universal type of test? I know that there's been a lot of advances there. Have you seen any improvements in terms of the genetic testing that maybe will make it a little bit more applicable to, as a general test?
So there are tests on the market that are trying to look at comprehensively look at cancer risk. So sort of the holy grail here would be you go to your primary care doctor, you get a blood test every year, and that blood test tells you that you have A, B, or C risk and, gives you that assessment. And there is a lot of work in combination with, both genetics, artificial intelligence and that is being put into those type of tests. They're still not mainstream at this point. There are opportunities, but the data does not really support their broad use. However, I do think that in the next 10 years, we will see that come into the mainstream as AI helps us find AI is very, very good at finding patterns, and really what we're looking for in genetics is patterns and being able to analyze very, very large amounts of data. And so I do think AI is going to have a big impact in how these VUSs get interpreted and eventually get converted into either benign findings or high-risk findings or pathogenic findings. And so I think to answer your question, I think there will be dramatic improvements. We are seeing an exponential growth in our understanding of genetics. I think we know more now than we did, say, 2 years ago. And by the way, pancreatic cancer screening was not even available 2 years ago. It was only under study, and only in 2022 was where the data came out where this makes sense to apply this to the general population. To be able to offer it as a modality of entry into a high-risk program. So I just want to be, I want to be very clear about the fact that the sophistication of this is growing, and the ability for us to be able to find things earlier is improving, but we do have ways to go.
Awesome. And I'll follow it up with one more question, and then we can open it up to the group. I think, people in general, I know a lot of folks that would sooner get an oil change for their car than they would get some kind of screening for their own personal health. What's the kind of the general message that you would want to say to a person like that in terms of how they manage their own healthcare, and maybe just hit on a few important things that everyone should be doing to make sure that they actually stay healthy and have the opportunity to perhaps have an early intervention if something does come up?
Well, it's the old adage, an ounce of prevention is a pound of cure. So we are able to catch a lot of things very early where, a small procedure, can potentially, alter an entire course of somebody's life. And I think people don't, they don't really take care of certain things until, it's too late. And I think one of the messages here is, if you have an extensive family history of cancer, you have an onus on you to check, because if you check, you can prevent, and if you can prevent, then you can extend the life not only of yourself but of your whole family. Remember, these are familial diseases. You need to understand how the entire family can be impacted. And oftentimes what we see is families that have multiple different types of cancer, but it is one gene that's causing all of those types of cancers. And so understanding that one gene and knowing that that is in your family, can impact everybody that you love. And so I think it's a very important thing to keep our community healthy, to become educated about this topic, and to be very proactive with your own health.
Awesome. Thank you so much. Let's open it up to the group for some questions. All right. There you go, Carrie. Let's get you unmuted.
Good morning. I saw my hand was hidden, so that's why I went like this, because it's yellow. Anyway, thank you for speaking. I was looking forward to this today. I have breast cancer in my family. My sister got it at age 30. My half sister, they said it was from too many hormones. She got through it, thank God. 2 years later, she got leukemia. So she's been through the ringer, but since then, I am getting tested. I was tested for the BRCA gene. I do not have it, thank God, but on a yearly basis, I do go and, I get the tests. I get, not to be too telling you TMI, but, you know, the mammography, the MRIs, sometimes biopsies, you know, and I'm a true believer, if you catch it early enough, you know, you might be, you know, it's not guaranteed, I know, but, you know, it's a scary thing to go through, but with, you know, everything that we have out there to help us diagnose or to prevent, you know, why not? And I know CentraState is a very well-known organization. And, you know, anyway, I just wanted to say that, but if anybody's hesitating, I have friends that hesitate. And I never thought I'd be going through this stuff. Nobody ever thinks anything, but you know, I beg them. I'm like, you found this, you have to go early diagnosis. You know, sometimes we don't want to do those things, but we have to. I do see that you have some sort of screening. Somebody, MDY chemo 01 sent that, and it's for the head, neck, and thyroid. I do have thyroid, Hashimoto hypothyroidism, so I would assume, is that phone number yours, so I can call to get more information on that?
Yeah, I think we'll get to Mary. Yeah, Mary Ellen's got some information on screening, so you
Okay.
want me to share that? And I don't know if the doctor wanted to comment as well.
Yeah,
And
I
I'm
mean,
sorry, what was the type of doctor that you are again? I missed that name.
so I'm a hepatobiliary surgeon. So in my clinical practice, I treat essentially all cancers of the liver, pancreas, and then also deal with a lot of abdominal tumors and you know, essentially abdominal tumors. You know,
You
it's
happen to
you know,
deal
it's
with
just a fancy word for pancreas and liver.
Yeah.
But
I have
what I
some,
would say is, you know, in the setting of, you know, like breast cancer and leukemia, you know, one of the important things, and I you know, I just want to reiterate your point, how important it is to get screened. You know, one of the big opportunities in that setting is to, you know, really look at, is there a genetic link there? And then the other thing is there are opportunities with hormonal therapy for chemo prevention in breast cancer. So if people have an overwhelming risk, but let's say they, you know, it's not high enough where a mastectomy would be indicated, let's say, one of the things that's an opportunity is to get chemo prevention. So we have in our breast center, we have a high risk nurse practitioner who's a you know, trained and kind of board certified in a specialized form of genetic testing applicable to breast and how it you know, and how high risk breast cancer works. And you know, I would highly suggest that may be somebody that you should speak to, because there may be opportunities either for chemo prevention, additional screening, and really obtaining a better understanding of where this whole process originated from, both in you and your family.
thank you. Just one more quick question, kind of on a personal. I have somebody in my life who has chronic pancreatitis for about 8 years now, and a lot of doctors just shrug their shoulders. Do you do you work in that field, or just
Yes.
that would be something?
Chronic pancreatitis, one of the important things there to understand is that you have to figure out what the sort of origin of the chronic pancreatitis is. You know, sometimes it is from common causes, but sometimes it can be from genetic causes. In addition, chronic pancreatitis is a predisposing risk factor for pancreatic cancer. And so we, you know, there may be opportunities there to observe that pancreas depending on the context. So I would, you know, recommend that individual see a pancreatic specialist and you know, get that assessed.
And you're a pancreatic specialist?
Correct, yes.
Okay. All right, thank you.
Awesome. Thanks, Carrie. Mary Ellen, did you want to go just kind of quickly talk about the screening that you have, and then we can continue with questions?
Yeah, sure. So we have monthly screenings. We work close with the cancer center. This particular one, head, neck, and thyroid, we catch a lot of positives here, which we can refer after that, you know, make a referral. We do get a lot of people for this screening. We happen to have openings. It's next week. So the number's there if you want to. I can share with Howard maybe the flyer for the year, you know, the whole year schedule. That might be helpful.
Absolutely.
Yeah. big into prevention here at the Health Awareness Center. I actually, just another personal story real quick. I have a cousin that was going to Sloan, and he was kind of delaying. He was diagnosed with prostate cancer and thyroid cancer at the same time. He did have surgery, but he delayed a little bit and it ended up being metastatic. So I remember talking, Dr. Itskovich actually looked over his stuff and said, just tell him to take some kind of action. But I felt like, not to put Sloan down, but it was kind of delayed just when he could get in for surgery. Quick, once you're diagnosed, and Dr. Itskovich can definitely speak on this, is taking some kind of action after you're diagnosed quickly. His sister lives in Freehold and is actually coming for a thyroid biopsy next week with CentraState. And, you know, again, he had family history. His dad, you know, died very young. So, I mean, I've been passionate for a long time about wellness and prevention. And as many people in this department, really, we do a lot of screenings to kind of, you know, diagnose early and to try to catch things early. So I'll send that to you, Howard. And I don't know if Dr. Itskovich wants to speak anything about the thyroid screening.
Yeah, I would just, you know, I just want to add, you know, we, you know, we're quite privileged at CentraState. We have, you know, a national authority on thyroid cancer, Dr. Alex Schifrin here, who's one of our physicians. And I think, you know, really, I mean, you're really getting treated by one of the best in the world in terms of, you know, thyroid disease. I think, you know, just in general, action is very important. I think that what happens in, you know, a lot of major centers is, you know, your appointments get pushed out 2 or 3 weeks, and then another week here, another week there. And then, you know, you realize you're a month and a half out or 2.5 months out until treatment's initiated, and things are still moving along. I mean, one of the things that we really pride ourselves on here is access. It is a, you know, one of my biggest priorities is the, you know, sort of my medical director hat on, to try to see if we can get every cancer diagnosis in, you know, preferably within a week. Because I really do believe that, you know, timing matters. And having gone through, you know, cancer in my own family, I can tell you, you know, not only on the professional level, but on the personal level, that waiting period plays a big impact, you know, psychologically on the person, the angst of not knowing what's going to happen. So it's very important that we get into prevention programs and not ignore problems if they're clearly visible.
Yeah, absolutely. And, you know, that's the whole purpose of a presentation like this, especially because it is, you know, an awareness month. So Mary Ellen, definitely getting those screening dates out, I think is something that we absolutely 100% want to do. And that is, you know, that's where I think our missions actually align in terms of education and wellness, right? So we definitely want to share that. And I'm happy to do that. Let's see if maybe we can take 1 or 2 more questions if there are any. Anyone have a question?
I'll jump in, I guess. So I actually had thyroid cancer and had my thyroid removed in March of 2001. It was that long ago. I didn't have any family history. Nothing was in, you know, I didn't obviously, who expects to get any kind of cancer. Is there anything I can do to make sure it doesn't come back? I mean, my thyroid's gone, but how do I know that nothing else can happen because I had thyroid cancer and it was years ago? So,
well, I would say that, you know, given the fact that there's, you know, there's a, you know, now it's been, you know, sounds like over 20 years since you've had it. I mean, in all likelihood, it was cured from the original operation, but that doesn't prevent you from having to, you know, do your yearly mammos and get your colonoscopy and do all of those other preventive measures. Generally speaking, thyroid cancer in and of itself, unless there are particular markers on it, you know, you wouldn't necessarily genetically test everybody. However, I would speak to, I don't know if you follow with an endocrinologist or your primary care doctor. They can look at that in a little bit more detail and see if you'd be eligible for something.
Okay, thank you.
Awesome. One more question, if anyone
Yeah,
has
just
it?
one more question,
Go ahead,
Howard,
Tara.
for the doctor. My husband's dad died at 55 years old of pancreatic cancer. So that's always something that worried me. I mean, your statistics make me feel a lot better. But for this pre-screening, let's just say his general practitioner says, yeah, I think that's a good idea. Is there a way for insurance to cover this at all, this testing, or do you find yourself, you saying that this is mostly out of pocket?
So at this point, given the change in 2022 guidelines, we see almost 100% coverage with insurances. Like in the past, I'd have to send letters to the insurance companies, but now it's universally covered as long as you're following what's called the CAPS Consortium guidelines. So, and the American Gastrointestinal Association also put out recommendations on this now. So because the societies have formal recommendations, the insurance companies essentially have to follow those. So it's really not a problem if, with one first degree relative with pancreatic cancer, that doesn't necessarily mean you need to screen. But one of the things that I would recommend in the setting of your husband is to be genetically tested. And if he doesn't have anything, in terms of his genetic testing, he's at slightly increased risk, but it's not worth, doing that yearly MRI. But if we do find something on the genetic testing, well, in that situation, then you would initiate testing and it would be fully covered.
And you said that was just like blood work, correct? The genetic testing?
Correct.
Okay. That's awesome to hear. Thank you so much. You were really informative and kind of eased my mind a little bit here.
Awesome. And I agree 100%. And I want to thank the doctor for coming on today. This was very informative. I actually learned a lot from this, and there are certain things that I need to take care of myself personally. And this was a great reminder for me as well. So thank you. We appreciate your time today. And thank you so much.
Thank you for having me. And like I said earlier, we are we at CentraState, we have a very large program now with a broad array of subspecialists to take care of a variety of these problems, and we're always happy to help. And take a look at our website if this is something of your concern, and certainly speak to your primary care doctor to see if this is something you'd be eligible for.
Awesome.